Today's presentation is Building an MBMA Framework to Support Developing New Neuropathic Pain Drugs. Today's speakers are Letitia Arrington and Richard Francesi. Letitia is currently a senior scientist in the pharmacometrics group at the Department of Quantitative Pharmacology and Pharmacometrics at Merck. She's also currently a PhD student studying item response theory in clinical trial optimization under the supervision of Dr. Mats Carlson in the Pharmacometrics Research Group at Uppsala University. At Merck, she contributes to study design, analysis, and reporting of human PK/PD to support clinical drug development. She has interests in neuroscience and infectious disease. Joining Letitia is Richard. He's currently a consultant at Certara based in Raleigh, North Carolina. He has expertise in population PK and PK/PD modeling and simulation and model-based meta-analysis. Richard holds degrees in physics and a doctorate in engineering from the University of Oxford. He has therapeutic area expertise in infectious disease and cardiovascular disease. Richard and Letitia, welcome to today's event. I'll now turn it over to Letitia to begin today's presentation.
Thanks, Suzanne, for that very nice introduction. And it's a pleasure to be speaking with you all today. Before we get started, I wanted to go through an outline of today's presentation in today's webinar. So we'll start with a brief introduction of neuropathic pain and also model-based meta-analysis. We will discuss how MBMA can be leveraged in clinical development, and then share with you some results and learnings from our recent collaboration. But before we do that, now that you know a little bit about us, we would like to know a little bit about you. So Suzanne, would you mind going to the Mentimeter poll? Seems like we've lost some sound here, maybe? There we go. There we go. Okay, so just give you guys a moment to fill out the information regarding what is your background. Is it pharmacometrics, clinical pharmacology, or neuropharmacology? We'll take a few minutes, seconds to fill that out. Okay, the responses are slowly coming in, but it seems like we have a large, in comparison, there's a couple of pharmacometricians on the line, so that's good to know. And perhaps as the results come in, it may be more clinical pharmacology focused as well. We can go to the next question. Oh, neuropharmacology is popping up. That's good. So we would like to know if the folks on the line have any experience in neuropathic pain research, since this is the primary focus of this presentation. All right, slowly coming in. So far it's about even, half and half. And I'm sure there are some votes that have not been counted yet. still seems to be pretty even. Well, as those results keep coming in, we can, I guess, move forward into the presentation. We know that it's about half and half for everything that we've asked so far, so that's good to know. Have a better understanding of our audience here. All right, so let's get into it. What is neuropathic pain? It's defined by the IASP as pain caused by a lesion or disease of the somatosensory nervous system. It's one dimension of the chronic pain syndrome, and it affects about 7 to 10% of the population. It can be characterized as increased activity and dysfunction of peripheral sensory nerves or nerves within the central nervous system, and it can derive from different conditions such as conditions associated with infectious disease or cancer or stroke. There are, however, primarily three very common neuropathic pain diseases, one being diabetic peripheral neuropathy, post-herpetic neuralgia, and also fibromyalgia. DPN is a diabetes-related damage to nerves that sit on the surface of the skin, and the major cause is uncontrolled blood sugar and high blood sugar, and it usually affects the extremities and can either be extremely painful, with like painful allodynia, or result in numbness. And these strong sensations can lead to neuropathic ulcers and amputation, and approximately 50% of the type 2 diabetes population does suffer from this disease. PHN actually is caused by viral damage to nerve cells after a shingles infection and mostly occurs in older adults over the age of 60. It can be described by burning, stabbing, gnawing, and the affected areas of the body may be hypersensitive and may also have decreased sensation. Fibromyalgia affects 3 to 6 million individuals in the United States alone, and is characterized by widespread musculoskeletal pain, tenderness accompanied by fatigue, sleep, memory, and mood issues. And it tends to affect those in middle adulthood, but the underlying cause is still unknown. While the treatment centered around these diseases is to focus on improving the quality of life, these diseases are very painful, and individuals suffer greatly from the pain that is invoked. And they don't respond well to weak opioids or traditional analgesics. There are several drug classes of medications that have been developed for other purposes, but have been employed in the treatment of neuropathic pain. For example, anti-epileptic medications, tricyclic antidepressants. But some of the most common medications used to treat neuropathic pain are gabapentin and pregabalin from the A2 delta class of antiepileptics, and duloxetine, which is a serotonin reuptake inhibitor. So the treatment of chronic non-cancer pain has been very challenging, and from a physician standpoint, the treatment plans attempt to use several other medication classes before turning to opioids. As you are probably well aware, there is an opioid epidemic, and this is actually an excerpt from a paper that demonstrates the massive increase in neuropathic pain spending. In 2016, you can see the rise for spending and also the dispensing of prescription medications. But in 2016, non-discounted pricing for pregabalin was upwards around $5 billion US. And a raise in spending and dispensing may also indicate a raise in prevalence of disease as well. So there are several components that create challenges in clinical development for neuropathic pain. One particular component is patient factors. Because pain is subjective, it's a subjective sensation, and it's dependent upon how the brain processes pain and the location of pain, and it's also unique to the patient's experience. This will have an impact on patient-reported outcomes. Not to mention that also kind of ties into the large placebo effects that are often observed in pain trials and in pain treatment. And Richard will go over some examples in the data a bit later on that point. As well as with the development of trials, there are particular inclusion and exclusion criteria, and some of which may require a certain baseline score from a patient to be included within a trial. But baseline scores will still vary, and subject may respond differently to treatment because of that. Other factors from a trial design perspective create additional challenges. For example, selecting the appropriate instrument to measure the primary endpoint, it's critical to evaluate efficacy. Pain intensity and reduction in pain intensity are the fundamental measures of efficacy in analgesia. And some of these instruments are, for example, visual analog scale, numerical rating scale, and there are several others. Also, there may be a lack of active comparator controls in development for several reasons, but NBMA can kind of work with that a bit more. And then efficacy readouts can be impacted by trial design elements such as trial or treatment duration. So this makes it difficult to compare trials head-to-head. Model-based meta-analysis can be leveraged to start to chip away at some of these challenges that I have described. So what is it? It's a quantitative framework that uses PK/PD and statistical modeling for leveraging external data to inform drug development decisions. So how does MBMA use external data to inform these drug development decisions? It does that by focusing on some key questions. First, what can we learn about our novel compounds in development compared to the standard care treatments? And meta-analysis can provide an indirect comparison to better understand the competitive landscape and predict outcomes for our internal compounds. How do drug classes differ with respect to their safety and efficacy profiles within specific indications? How do various efficacy endpoints relate to one another? And again, Richard will kind of demonstrate some of that in the second half. And then what is the impact of trial design and patient characteristics on clinical outcomes? And are we able to identify sources of variability? And lastly, which is very important, can we characterize placebo and treatment effect? So in our case, we use external public clinical data, but also preclinical data can be used in the same way. But the external public data and literature or published trials is collected, creating a larger database of prior knowledge and is used to then develop a model that can be used to simulate and predict parameters such as efficacy and other outcomes, as demonstrated by this figure here. This framework, when leveraged along with other learnings in the drug development process, can help inform decision-making, making go, no-go decisions, trial design components as well. And it's an iterative process similar to other approaches in MIDD. So the value of MBMA compared to, let's say, more traditional meta-analysis is that it incorporates parametric models for the effect of treatment time and patient population characteristics. It can include trial-level covariate relationships on a dose-response model to account for between-trial differences in patient populations. It also incorporates the effect of dose and duration using standard pharmacology models and assumptions. It allows for simultaneous modeling of multiple endpoints, which Richard will share with you, and also has been demonstrated to be used to link biomarkers to clinical endpoints. And an important component is that it also uses longitudinal dose-response models for individual drugs or drug classes. So why do we choose to leverage MBMA in neuropathic pain? We wanted to position ourselves for the future and start a process of data gathering and to better understand the competitive landscape earlier in the development cycle. One thing to note, all pain is not created equal. So there are different mechanisms for the pain pathways, and they require different experimental clinical models. There's also a benefit to translate between different measures of pain intensity, pain relief, and responder rates in this space. There may be a case where a trial may have one endpoint and not another, so it allows you to utilize more data that's available. Also, a translation between short-term treatments and longer-term treatment durations is very key in this therapeutic area. There are, however, some considerations when employing this methodology. First, dose response. What type of data do we have from a dose response perspective? Is there a limited dose range? Is there only labeled dose, clinically efficacious dose available? Do we have time course information available? Also, how do you plan to handle trial heterogeneity? And then also the covariate distribution. For example, do we have a wide enough age range as a covariate to inform future inclusion and exclusion criteria, and how do we interpret the results? So we used an extensive clinical trials outcomes database from Cetera. It was developed from a systematic review of the literature based on predefined inclusion and exclusion criteria, some of which are shown here below at the 3 bullet points. One important note is that it is summary aggregate data, so it is mean data, not individual information. Also, it included randomized placebo and active control trials, and the study must be published after 1990 and have a sample size greater than 20. We focus specifically on DPN, PHN, and fibromyalgia to be in line with our overall strategy. The endpoints we evaluated were average pain change from baseline and responder rate, specifically the proportion of subjects that achieved 30% or 50% reduction in pain. These endpoints were selected based on FDA recommendations for efficacy in neuropathic pain. Also, from a covariate perspective, we utilized the information that was in the database that was available to us that had a even distribution so that we could evaluate these components. But for example, we looked at age, race, baseline pain score, disease duration, imputation method, trial year, and region, and also treatment duration were applicable. So now I will turn it over to Richard, who will walk you through some key model development components and findings from our work.
Thank you very much, Letitia. So I'm going to begin with an overview of what data we had available. So we've got 3 diagrams and 1 table, and the 3 diagrams are network diagrams. In these diagrams, each node or circle is a drug, and then the line connecting 2 nodes is saying there's a trial that compares these 2 drugs head-to-head. And as we get thicker and thicker lines, that means there's more and more trials. So pregabalin is a very thick line with placebo, and also as these circles get bigger, that means there was, again, more trials of that particular drug. So we see immediately in these diagrams, DPN has a lot of connectivity, and actually about half of the entire data set was for the DPN indication. And as we go to PHN and fibromyalgia, we have a little bit less, but we still have a sufficient amount. And one of the valuable things with MBMA is all of this data is fit together in one model. So we can leverage the data from each indication in the full model. So what we see in those diagrams is for the average pain endpoint, but it's largely the same story for the responder rate endpoint. In the actual table, we see the bottom row there is 30,000 patients in the average pain data set and about 26,000 in the responder rate. So that's similar magnitude of each endpoint. And in terms of the number of drugs, we've got 31 and 22. So really, there's a lot of drugs that have been thrown at this indication already. And there's hundreds and hundreds of treatment arms. So here's a little bit of a deeper look into the data to outline some of the nuances we had to face in the actual analysis. So on the right-hand side is a picture, and this is a density plot of the mean age for each indication. And the important thing to note here is they do not overlap, so they're confounded, and that presents some challenges for the modeling. It means that in this particular case for mean age, we have indication-specific covariate effects. And that was generally the case with, or we took that approach in almost all the covariates because we had these unbalanced distributions. So the same was true for the mean disease duration distribution. So typically, these are different patient populations, and fibromyalgia patients have had about 8 years of disease duration before coming into a trial, whereas DPN and PHN is somewhere close to about 3 or 4 years. So these are all considerations going into the actual modeling, about caveats, And the really big caveat here, which Letitia spoke to, is we're dealing with mean summary level covariate effects. This is not individual covariate data. This is summary level. So there is certainly an element of caution with interpreting and fitting covariate effects in MBMA. So here is an overview of the average pain model. I'll take you through it step by step. So there are three portions of this model. We have a placebo model, a drug effect model, and a covariate model. On the right-hand side, we actually see a picture here of the time course of a typical average pain value. So that we start at time 0 with a baseline, change from baseline is 0, because we're starting at baseline. And as time progresses, the pain score out of 100 drops. So that's good. And in fact, in terms of the actual amount of drop, that's determined by the magnitude of drug effect, which is a simple Emax model in this case. And how quickly that occurs is determined by the time onset parameters. And in fact, in that left arrow, we see about half of the maximal drop, and that refers specifically to the parameter estimate ET50. So when do we get to half of that real dropout? And then finally, gamma, that exponent there is telling us, well, how sharply do we drop around that point? So these are all factors to the characteristic curve, and the actual equation for the drug effect model is on the left as well. Taking a slight step back with the placebo model, we chose to take the approach of a non-parametric placebo model, because that's driven by what our question was. Our question was, what's the drug effect? So what that model does for the placebo model is it says, let's fit a parameter for every time point in each trial, and then what remains is going to be attributed to drug effect. So that means that we are really focusing here on the drug effect and what that explains. In that drug effect, there are some pharmacological considerations. So with a drug class, what we're assuming here pharmacologically is every drug in a drug class has the same method of action. And for that reason, we would expect the same efficacy for any drug in that drug class. So that parameter Emax and also the time onset parameters are class specific. However, within a drug class, if you've got several drugs, you might expect a different potency. So the dose you have to take to get a particular effect might be different. So that's the ED50 parameter that we fit to each drug. So these are important considerations in how we fit the data technically. And on top of that, as I've mentioned before, these also have the capacity to be indication specific. And we tested that in a stepwise fashion. And finally, the covariate effects are also indicator specific, and we're typically testing those on the Emax parameter and the time onset parameters, so at a class level. And we also investigated, which I'll talk about briefly later, a capacity for the potency to be indication specific. So that's broadly the outline of the average pain model. And now I will talk about the responder rate model. Excuse me. So a couple of differences, but it's largely the same. So structurally, there's a bit of a change in the drug effect model, but the placebo model is the same approach. We're still interested in drug effect. That diagram on the right is a dose-response curve. So if we go from left to right, the dose gets higher, and the responder rate increases. So we're saying that a higher dose, well, then that means more people, or a higher proportion of people, are going to achieve a 30% response or drop in pain. And there are actually two curves here because we use a joint response model. So in that model, we've got a parameter to link 30 and 50% response rate. And naturally, fewer people will have a 50% reduction in pain than 30% reduction in pain. So that top black line is for the 30% reduction in pain, and fewer have a 50% reduction in pain. But what we assume is that there's a parameter to associate the two. It's still a simple Emax dose response curve. And one of the challenges with the responder rate data is that we only really get one or two observations for each trial. So what's different here is there is no time onset parameter estimation. We did try it, but it just didn't actually turn out to be estimable. However, it is still longitudinal data because there are more than one, in many cases, observations for each trial. So lots of similarities. The same approach is taken for how we do Emax class-specific estimation and ED50s, and the same for covariates. And in fact, as the curve is really showing, as you go more doses, greater response. So it's a slightly different direction. So I just said a lot about, we assume that the 33% responding rate are going to be correlated because there's a parameter. So if we look at the data, we see exactly that. That graph on the right-hand side is a relationship between the 30% and 50% responding rates. And those circles are observed, or observations. Larger circles are essentially saying there's more people in each trial. And the fit, that line, is a weighted linear regression. So the relationship is very linear. And one thing I should note is actually, in this responder model, because it's a bounded scale between 0 and 100%, we actually perform a loaded transformation and then do the modeling, and then after that, or do the fitting rather, and after that we then transform back to a percentage. So we get back onto this scale of 0 to 100. So yes, there is a high correlation between these two endpoints. We can account for that in the model. And there's also clearly variability around that line. And on this parameter EK, we actually have a random effect for between trial variability. So I've described two models, and they both bring different useful pieces of information to the table, as well as being requirements for the FDA. But they tell us a really good story of the whole area. So first of all, as Letitia said, responder rate model. Well, why we have that? The FDA actually recommends a success-failure criteria, a yes or no. Was your trial a success or was it a failure? And we can ascertain that by using the responder rate endpoint. And in their draft guidance in 2014, they give an example of the 30% reduction in pain endpoint. What percentage of people have that reduction? So that's incorporated in our model, but we also have a 50% reduction in pain endpoint. Why that? Well, with a joint response model, we can leverage a single trial that only had 50% response measured and include that in the data set with other trials will have both or have the 30% responder rate. So this framework allows us to have more information and get more confidence in what conclusion we come to. Secondly, if you're trying to benchmark your current results with previous results, you may have to compare against a different endpoint. So we can facilitate that with our particular model. And then finally, during the trial, if you're getting a 30% response rate observation, that will, of course, you'll hit 30% reduction before 50, so there's a possibility you can predict the 50% response from your interim data with 30% response. And then if we go to the average pain model, there's a different set of information we get there. And this is a key efficacy endpoint for the FDA insofar as it's a pain intensity score rather than a success failure criteria. So it's telling us a different side to a multi-sided coin. So the interesting thing with this particular data was there was a far richer sampling scheme. So there was a time course that you could typically see. And you really couldn't get that from the responder rate data because it was only taken at the primary endpoint or maybe twice. So we got to see really how pain scores progress with time, and that's useful because it means when you're looking at a trial, you might be able to see how long might I need to run this trial and when do I need to take measurements to try and see more granularity on the dynamics. So between the two of them, these are different pieces of information of value. So now we're seeing actual observed data again. This is the average pain model, and it's the placebo response data. So those circles are observations for trial arms, of placebo trial arms. And we've got a purple line through there, which is a low S fit, or a local weighted regression fit. And we see that the drop occurs with time, as we saw in that previous picture with the typical drop in pain for average pain. So that red line is actually trying to give you an idea of what the drop in pain due to placebo is at 12 weeks. And we see that they're actually different for each indication. And also they're large for every indication as well. So we're seeing a drop in pain score at about 14 to 20 points just due to placebo. This is obviously clinically meaningful and important to consider in any trial design. So what's happening here is also a slight difference in indication. And in fact, in terms of how large this is compared to drug effect, it's about twice as large as the drug effect at label doses for the major drug classes, and it's also far slower than the onset of drug effect in the actual data.
Richard, I just wanted to interrupt for a second. Someone wants to know what do the sizes of the circles denote?
Oh, thank you. Yeah, so the size of the circles are really reflecting how many subjects were in each trial arm. So a larger circle is saying we had more subjects in that trial arm. And what that means, modeling-wise, is it's saying that has more weight in the fit. So we have more confidence if there are more people in the trial arm. Thank you. Thank you, very good question. So there's an implication here related to the previous slide about what happens during the trial. So if you're in a trial and you're observing a drop in pain score after about 3 or 4 weeks, given that the onset of drug effect is typically very quick for major drug classes and a lot of other drug classes too, really we can probably attribute those further drops after a month to the placebo drop. And that's an important consideration when we're looking at the actual trial specifically. So here we have estimated drug effects and relative to placebo for several drugs in the modeling data set. This is only for DPN. And we've chosen doses based on either label doses or what we had in the data set. In some cases, we had 1 or 2 doses to choose from. We've got a color scheme here, which is grouping each drug class. So we see a few clusters here and there for same color. And that black line on the right-hand side is the baseline pain score, so that's just 0. It's a change from baseline pain score model. And then, interestingly here, we have this orange dashed line. And that refers directly to the red line in the previous slide, which was telling us what was the drop in pain due to placebo at 12 weeks. And we have about -18 for DPN. And the further shift to the left is what remains due to the drug effect. As we go from top to bottom, we see more and more efficacious drugs at those doses. And we also see these 2 red arrows reflect the drugs that are actually approved. So duloxetine is second from bottom at 60 milligrams. We see a drop there that's about half of the placebo drop in that drug. And pregabalin is also there at around a third. So really this for me is saying the drugs don't do much more than placebo. Now, they're significantly different, but we have to ask the question of can we do better? And I think to what Letitia said before, a lot of these drugs were developed for one of indications and now being applied to pain, and it's noticeable that several drug classes are really ineffective. And I think one other thing to consider in this is these stars are really cases where only 1 trial was in the data set for that particular drug. And understandably, a lot of these are actually close to 0 because naturally, if a drug for 1 trial fails spectacularly, you won't do another. So really, the take-home message here is drug effect is quite small relative to placebo, and even for the approved drugs. Now we've got the summary for the responder rates. The difference here is this graph looks different. So as time goes on from the placebo response, more and more people respond with a 30% reduction in pain. So the graph looks different. We have the same circles representing observations. Bigger means more in the trial arm. And we have a local weighted regression fit through the data. So clearly, once again, we see a different maximum or a different value at 12 weeks. We see a different characteristic curve for some of these. For PHO, is quite different to the others. And we also see different amounts of data. So I was speaking earlier about how much data there is. DPN really is the lion's share of the data. So PHO is clearly underserved as an indication with very few trials in that. So same story really, placebo response is large, it varies, and it takes a while to have onset. And the thing with this particular model that was just really a constraint with the data is, as I was saying several times now, we only have 1 or 2 observations for each trial. That really affected how we can characterize time onset. Essentially, we could not estimate time onset parameters for any drug class. So we have to assume in this case that that is an arbitrarily fast time onset, which of course is slower than what we've seen in these graphs. So again, we've got estimated response rates. This is for the 30% responder rate. Naturally, the 50% will be about the same, just closer to the placebo. So that dashed line, once again, is the placebo response, and it's 41%. So that's quite incredible. It's saying that at 12 weeks, if you're on a placebo, 41% of people will have a 30% drop in pain. And then on top of that, the drug effect is really only about 10 to 15%. So again, the drug duloxetine at 6 milligrams is right up there with one of the larger increases on top of placebo, but really all the drugs are about 10 to 15%. So we have to ask, can we do better? And again, it's even more noticeable here, actually, about how the drugs with only 1 trial are all languishing down at the bottom. So some key findings then to summarize. There's a lot of information. So first of all, that placebo response does vary by indication. It was lower for fibromyalgia and DPH and then DPN. And then on top of that, the drug effect, compared to that placebo response, is about half or even less for the effect of the labeled doses, even for approved drugs for DPN specifically. Now, I haven't shown data about PHN, but it really is, and fibromyalgia, it's the same story. We also have this indicator specificity for covariate effects and other parameters, and that was really interesting here because in the average pain model, we actually improved the model by estimating different potency parameters for duloxetine in fibromyalgia and DPN. And in fact, if you go to the guidance for duloxetine by the FDA, they actually recommend different starting doses for duloxetine. So we found that, again, potency was higher for fibromyalgia, for duloxetine and fibromyalgia, and the recommended starting dose is lower. So that was a really interesting thing to come out of the actual data, to corroborate really and give more confidence in what we're really finding. And then also there are some potential covariate effects of mean age, disease duration, baseline score. Baseline score is obviously typically going to be important for these kind of scales. And that will help inform inclusion of the student for future trials. But the real caveat here is, again, to revisit, we're dealing here with summary level data, so there's always a caution with interpreting those. So really, at this point, I'm going to hand back to Letitia to talk about benefits and conclusions. Thank you.
Thanks. So to wrap us up, what are the benefits and what did we learn from all of this that we shared with you today? One, there's a wide range of medications with varying mechanisms of action, efficacy, and tolerability profiles that have been employed in the treatment of neuropathic pain, and most of them show small improvements compared to placebo. While they're working, they're still small improvements, so that introduces an opportunity for continued identification of novel treatments and therapies. Also, treatment in neuropathic pain can't be generalized, as he demonstrated that the drugs are performing differently in different indications. Also, the placebo effect is different in different indications. So this could allow us to target particular indications within neuropathic pain with more confidence and increase the probability of success. Another benefit is the opportunity to rank order standard of care and compare our novel therapies in regards to the efficacy and safety potentials, and to help inform go, no-go decisions and getting these earlier reads in proof of concept stages even especially in the cases where active comparator arms are not included in this trial design. Also, again, a take-home is that this is using summary data, so therefore you have to be careful about the interpretation of the data and extrapolation of the meaning. And hopefully the take-home message is look forward to trying to employ MBMA analysis where you can and where it makes sense to leverage it as a tool to better understand your competitor and your compound, and it provides valuable information on treatment and placebo effects. I wanted to take some time to recognize and thank the rest of the team that contributed at both companies to this work, and their names are listed here on the slides. If you have any questions, feel free to reach out to us, or also see the posters that were presented in 2018 at PAGE and ACOP. This is the end of our presentation, and we would like to open up the floor for questions. Thank you.
All right, thank you so much, Letitia and Richard. As Letitia said, we encourage our audience to now submit your questions to the Q&A box in the lower right of your screen. So, Letitia, it looks like we've got a question for you. Someone wants to know, in cases where there's not a dose range, was an Emax model forced, or was some other model employed? How did you handle this?
That's a very good question, because there were multiple cases where there was not a large enough dose range and only the labeled dose. So other model structures were explored during the early stages. And for example, the gabapentin extended release formulation, a log linear model was employed there. And the cases where there were no dose range available at all and just a single dose, a constant or drug effect level on-off response was kind of assumed. And this kind of implied that the dose studied was already at the efficacious or close to the Emax level of the dose response curve. I'm not sure if Richard, you want to add anything else to that?
Richard, do you want to add anything?
For the question? No, I think Letitia captured it well. You know, we tested these in a stepwise fashion, and yeah, only one model that was parametric was really in there. That was gabapentin extended release.
Letitia, looks like we have another question for you. Someone wanted to know, have you done similar analysis with safety, the safety effects of dizziness and nausea, because those are common side effects seen in patients that take these medications?
That is another good question. So we did do a dropout model for AE, but the data that was available to us, we focused strictly on dropout due to any AE. We didn't drill down to the nausea and dizziness component. That could be something that we decide to do in the future.
Looks like we've got one more question, and it's for Richard. Richard, can you tell us what's the difference between using a parametric versus a non-parametric placebo model?
Yeah, I think, well, the thing driving that approach is really what the question is. So in our particular case, we were focusing on the drug effect. So we just say that it's a non-parametric approach, and we attribute all the remainder to the drug effect. And yeah, that does have one of the drawbacks of perhaps overestimating being slightly more imprecise parameter estimates, but you know, that's one of the trade-offs. And with a parametric model, really, we have to go through the process of building it from scratch, so it doubles the modeling effort, because each individual indication may or may not have a particular parametric model. So really, if you're interested in the description of that placebo response specifically, then yes, you go ahead and you really try and describe that parametrically and see what you might influence. And as part of using a parametric model, you could also have some variability or unexplained variability in that model that would account for some of the change, so that you might get better estimates on the drug effect parameters if you do that. But you know, the approach we took was really driven by the drug effect. So yeah, that's what. Yeah, what question you're asking is really what's going to determine the difference.